Okay, so now we have intestinal malrotation in pediatrics and its radiologic features by Dr. Sarah.
Okay, hello everyone. Today I will talk about intestinal malrotation in pediatrics and its radiological features. So we will talk about this malrotation and its symptoms, the position of duodenal junction and ligamentum of trees, and the radiological features of malrotation. So malrotation, it is an anatomy, it's a congenital and anatomical anomaly. It results from abnormal rotation of the gut as it returns back to the abdominal cavity during embryogenesis. So, in order for us to understand the malrotation, we should have an idea about the normal embryogenesis of the midgut. The embryogenesis of the midgut is divided into 4 stages. We have the physiological herniation, the rotation, retraction, and fixation. So, normally the midgut inside the abdominal cavity during fetal life, in the 5th to 6th weeks of gestation, it will be herniated through the umbilical cord to the yolk sac. Once this herniation will occur, it will be start to rotate around itself, around its axis, and the axis is superior mesenteric artery. The whole angle of rotation is 270 degrees, but it will not occur continuously. It will occur like in 90 degrees, then stoppage, and again 19 degrees. After this rotation, once the rotation finished, it will be reduced back to the abdominal cavity and fixed through some ligaments in the posterior abdominal wall. Next slide, please, Victor. So, the ends of the alimentary tract, we have 2 ends of the alimentary tract. We have the duodenal loop, which is the red arrow. It starts superior to superior mesenteric artery, and it will be rotated 270 degrees to the to be fixed in the in the left upper quadrant, while the cecocolic loop, it is the green arrow. It starts inferior to the superior mesenteric artery. It will be rotated 270 degrees to be fixed in the right lower quadrant in the abdominal cavity. And also we have the ligamentum trees. The ligamentum trees, it is the folded peritoneum. It fixes the 3rd and 4th part of the duodenum to the right crest of the diaphragm. Here we see that the 3rd and the 4th part, it will be connected to the right crest of the diaphragm. So any abnormality during this stage of development is called malrotation. Next slide. So malrotation is not only one disorder; it's a spectrum of disorders. It includes the non-rotation, the incomplete rotation, and reverse rotation. In non-rotation, here the midgut, it will be herniated, but once it's reduced back and fixed, it's not rotated. So we will see that the small bowel is on the left side, while the large bowel is in the left side, on the right side. Sorry. Here, usually the case
Small bowel on the right side,
and the
large
large
bowel
bowel
on the
on
left.
the left side.
Oh,
yes.
No problem. Accept.
Okay. Here the patient will be asymptomatic. Usually they will be presented in the adult life, not noticed, and it's lower risk for volvulus. While in the incomplete rotation, as we see here, there is a in the stage 2, there is a short mesentery, so more chance for volvulus. As Dr. Leila talked about the volvulus, we know that one of the risk factors of volvulus is short mesentery. So it usually occurs in incomplete rotation. And here we have the Latz band. Latz band is a fold of the peritoneum as well. It usually attaches the cecum to the abdominal, to the peritoneum. Once the attachment occurs, it will be the site of the attachment posterior to it, it will be obstructed. So usually the patients with incomplete rotation will have the obstruction in the 3rd portion of the duodenum because of the Latz band. And also we have the reverse rotation. Here the change in the direction occurs, while it will be the duodenal junction, which is here, is anterior to the transverse colon and superior mesenteric artery.
Normally it's posterior.
Normally it should be posterior.
Now it's anterior.
It's anterior to it because it is a reverse rotation. Next slide, please. So malrotation is approximately occurs in 1 to 500 live births, and its peak frequency is 2 months. Usually, any child presented with bilious vomiting, the malrotation should be excluded. Because one of the signs, the most sign of the presentation for neonates is bilious vomiting. Sometimes the patient might be asymptomatic with incidental finding. There might be associated with volvulus or Latz band obstruction, with ischemia or without ischemia. Associated features of malrotation, we have many associated diseases that present with malrotation, mostly the gastroschisis and omphalosis. Here, when there is herniation of the midgut to the outside the abdominal cavity, there will be problem in reduction. So the midgut will not be returned back to the abdominal cavity. The baby might present with gastroschisis or omphalosis. Congenital diaphragmatic hernia, here the problem is with the fixation. We have the herniation, rotation, and reduction, but the fixation in the abdominal cavity will not occur, so the bowel will go to the chest. And heterotoxy syndrome, it's a syndrome. Usually the patients will present with respiratory problems. Once a chest x-ray is performed, you will see that the heart is on the right side, dextrocardia. In such cases, we should do a fluoroscopy for the abdominal cavity in order to exclude malrotation. And also there might be duodenal stenosis, atresia, or small bowel atresia.
What's called double bubble.
Yes, this is double bubble sign of the atresia. The radiological features, I'll start with plain radiograph. Usually the plain radiograph is not specific, but in case of volvulus, it will be specific. We will see some signs of the volvulus. In the plain radiograph, if there is no volvulus, there will be right-sided jejunal marking, because as we said, the small bowel will be on the right side, and the absence of stool in the colon and in the rectum, and there might be sign of the small or large bowel obstruction, as we said, double bubble sign or large bowel obstruction. We have the ultrasound and the Doppler study. In the ultrasound, normally the superior mesenteric artery is on the left side of the superior mesenteric vein. But in case of malrotation, as we said, the axis is superior mesenteric artery. So the problem will be around the axis. The malrotation will not occur around the superior mesenteric artery. We will see that the superior mesenteric vein is on the right side of the superior mesenteric artery. Here we will see that here, this is the superior mesenteric vein, this is superior mesenteric artery. Here the same superior mesenteric vein, superior mesenteric artery, this is the celiac artery, and this is the aorta. Sometimes it might be associated with whirlpool sign. This is the rotation around itself. It will occur as a whirlpool sign. And also the third part of the duodenum will be retromesenteric. Here we will see the third part of the duodenum.
Retromesenteric.
Retromesenteric. Okay, we have also fluoroscopy, barium small bowel follow through, and upper GI. In the frontal view, normally what we see is that the once the barium will leave the stomach, it will be downward. It will be posteriorly and downward, forming this C shape, and then it will be upward. Like it will go upward, the fourth part of the duodenum. But in stage of malrotation, the small bowel, the fourth part of the duodenum and the third part of the duodenum will not cross the vertebra, will not go from the right side to the left side.
Yeah, this is the normal.
This is the normal. This is
it
the
should
abnormal.
go like that.
Exactly.
Ends on the left side of the vertebra.
Exactly.
While in case of malrotation, it does not
cross
the vertebra. It
Yes.
does not go like this.
Yes.
Okay.
And the duodenal junction should be posterior to the pylorus. Here we will see that duodenal junction is posterior to the pylorus. But normally, this is normal. But in malrotation, we will not see this.
Mm-hmm.
So this is again, we'll see that this is the barium. And here is the duodenum. It didn't cross the vertebra.
It did not go to the other side.
Yes. This is
The
lateral view.
You can see. No,
This
this
is
is
the
anterior.
frontal view, yes.
But again, you can see all the contrast on the right side, nothing on the left, because it's malrotated.
Okay, this is the lateral view. In the lateral view, the second part and third part of the segment of the duodenum are not located posteriorly and in retroperitoneal position. So we will see here. This is the lateral view. Usually, it should go upward, but here it's not upward.
No.
Because of the duodenal junction should be posterior to the pylorus. Next, please. Here it's associated with corkscrew appearance, which is also a complication of the malrotation. In case of volvulus, once malrotation predisposed to volvulus, it will appear as a corkscrew appearance.
Because it's around the SMA. So you see this corkscrew here. Again, you can see it here like this corkscrew. Nice.
This is also barium meal follow-through study. We will see in the 45 minutes after the follow-through, the whole small bowel is on the right side. Here we will see that after 2 hours, the large bowel are on the left side, the transverse colon and the whole colon is on the left side.
So basically, the small bowel on the right, the colon on the left.
Yes.
While should be the colon surrounding the small bowel.
Exactly. It will be
So?
Usually the large bowel should give a frame-like picture around the small bowel, but here it's not. We talked about Landsband. Here it's again we see here Landsband. It's a stock of peritoneum. It causes obstruction of the second part of or the third part of the duodenum. This is also a case of Carolina Lenangri syndrome. And this syndrome, usually the patient having malrotation. Again, we see that the large bowel is on the left side. This is the rectal enema.
And we see this all the large bowel on the left side. Okay. Which is basically the same as malrotation. Yeah.
Next, please. Okay, CT. Same findings in the abdominal ultrasound. When we said that the superior mesenteric vein is on the left side of the superior mesenteric artery, we will see it on the CT, and also in the CT we see that the stomach is distended with the duodenum as well. This is the Werthel's sign as well, and the large bowel is on the left side, distended. This is wandering duodenum. Here we have problems with ligaments. So the ligaments will be lax. It will not hold the duodenum tightly. So here we see that it might look like volvulus, but it's not, because there is crossing from the left to the right side of the duodenum, and we see that the fourth part and the third part of the duodenum is posterior to the pylorus of the stomach.
So there is no malrotation.
No malrotation.
Just the ligaments are lax.
Exactly, but it looks like malrotation. But once you focus on it, you see that there is a crossing from the left to the right side. This is also malrotation with the volvulus. We see that the Corkscrew sign.
This is the Corkscrew, and since markedly distended stomach indicating obstruction, with the bird beak sign you can see here.
Okay, so this case I saw in the Rakarim hospital. It was a 10-year-old baby. He presented with billar chromatin. They suspected malrotation. They did an upper GI study. I didn't see the plain abdominal film and abdominal ultrasound, but this is all I got. Any idea what is the diagnosis? Is it malrotation, or it is intestinal malrotation? We said in intestinal malrotation, the third and fourth part of the duodenum should cross the midline, which is volvulus of the stomach.
Gastric volvulus.
Gastric volvulus. It's organoaxial. Yes.
Organoaxial,
which is most common.
Because this is the duodenum, and it looks good. You're not crossing the C shape, and here is the ligament of treats, right? Nice.
So take home note: any child with bullous emesis should be presumed as malrotation with volvulus until proven otherwise.